In this unit, we are going to look at problems associated with the endocrine system. Inappropriate or abnormal target tissue responses can be assessed in terms of the source of the inputs that control it. In other words, is it the endocrine gland or is it the hormone output from the endocrine gland? First, looking at endocrine hypofunction. Here, the target tissue responses are inadequate. This could be due either to hyposecretion, not enough hormone produced by the gland, or a loss of target tissue sensitivity to the hormone. Here, the hormone is still being produced, but the target organ no longer responds to it. First, looking at some causes of hyposecretion. This might be due to agenesis. A means absence of, genesis means creation. This means that no gland was ever created, so a lack of gland development. If there is no gland, that means there will be no hormone. It could be the result of a genetic defect. This may cause a metabolic abnormality that prevents the synthesis of the hormone from the gland. It could be due to a dietary deficiency, where there is a lack of the precursors that are needed in order to synthesize the hormone. It might be due to damage to a normally functioning gland, so that now the gland is unable to maintain normal secretion. There was a gland, but now it can no longer function. This could be due to infection, infarction, or an autoimmune destruction of the gland. It might be due to atrophy of the gland. If there's not enough tropic hormone input, this results in a decreased demand for the hormones that are being produced by the gland. As a result, you will see the gland begin to atrophy. It may also be due to destruction of tropic hormone receptors that also will lead to atrophy. If the gland isn't being stimulated by its tropic hormones, it will begin to atrophy or to fade out. Usually this is the result of an autoimmune destruction. But again, this is not considered a type of agenesis. There was a gland, it just is no longer functioning properly. It may be due to tumor growth. This can cause a secretion of either no hormone or an altered hormone that doesn't function the same. And the last cause could be surgery to treat a hyperfunctioning state, where part or all of the gland will be removed. Regardless of the cause, hyposecretion is often accompanied by elevated levels of the control hormones due to the negative feedback response. Again, this chart shows all the possible causes of hypofunction. A genetic defect resulting in no gland development or defective hormone, a tumor, inadequate dietary precursors, damage to the gland or atrophy, reduced receptors, or a defective tropic hormone metabolism. We're going to look at the other effects here in just a moment. The second cause of hypofunction could be hormone resistance. This is an insensitivity of the target hormone, the target tissue to the hormone. So the hormone is still being produced, but the target tissue no longer responds. This may be due to a genetic defect, where the target tissue is unable to synthesize the receptors, or it could be due to a defect in the intracellular systems activated by the hormone binding. Typically, you will see increased levels of the hormone due to the negative feedback response to the decreased target tissue activity. So because the target tissue isn't responding the way it should, the endocrine gland feels the way to correct this problem would be to produce more hormone. It might also be due to an autoimmune disorder. Here, you make antibodies to the hormone receptors. If the antibody binds to the receptor, the hormone will not be able to. Looking at endocrine hyperfunction, this now results in an exaggerated target tissue response. This could be due to hypersecretion, where the circulating hormone is present in very high levels. This might be due to unusually high levels of its tropic hormone. In response to the increased stimulus by the tropic hormones, the gland may result in either hypertrophy or hyperplasia because it is trying to produce so much hormone it grows in response. It might be due to a defective feedback control that it no longer responds to the negative feedback, or it may be due to tumors of the gland, especially if the tumor tissue retains the ability to produce the hormone. The first gland we're going to look at is the pituitary gland. A little review first of the normal anatomy and physiology. The pituitary gland hangs off of a stalk called the infundibulum that extends down from the hypothalamus. The pituitary gland sits in and is protected by the sella turcica of the sphenoid bone, so the gland itself is entirely encased and protected by bone. There are two regions. The anterior pituitary, also known as the adrenal hypothesis, synthesizes numerous hormones, a few of which are listed here. The posterior pituitary, also known as the neurohypophysis, this portion of the gland does not synthesize any hormones of its own. All it does is store two hormones that are produced in the hypothalamus. These hormones are made in the hypothalamus and then migrate along the pituitary stalk to the posterior pituitary, where they will be stored. These hormones will then be released in response to action potentials arriving from the hypothalamus. These two hormones include antidiuretic hormone and oxytocin. Looking first at the anterior pituitary gland and problems associated with hypersecretion. Hypersecretion is often caused by a tropic hormone secreting adenoma. This is a tumor that secretes tropic hormones that will then stimulate the anterior pituitary. These adenomas are usually very small because there's no place for them to grow. If they do enlarge, they may end up compressing the optic chiasm because the sella turcica doesn't give. So again, they grow upward. If they compress the optic chiasm, this will result in vision changes, and also as it continues to grow, it can push on the brain, resulting in headaches. Signs and symptoms of anterior pituitary hypersecretion are often reflected in the hyperactivity of the target gland for the individual hormones. One hormone that can be affected is growth hormone. The effects of hypersecretion of growth hormone will depend on the age at when hypersecretion starts. If it occurs in children before the epiphyseal plates close, this will result in giantism. Here you will see rapid overall body growth. These children have the potential to grow to 8 or 9 feet. If the tumor is not removed or suppressed, it may end up destroying the gland due to compression. Death can occur at an early age without some sort of intervention. Acromegaly is when hypersecretion occurs after adolescence and the growth plates have fused. So instead of being able to grow longer, the bones now become thicker in response. You will also see excessive growth of the soft tissues. They will enlarge and often coarsen one's features. The internal organs will also be affected. Next, some conditions associated with hyposecretion of the anterior pituitary. This may be due to either infections, tumors, or injury or infarction of the gland. If this condition results in suppression of all or most of the hormone secretion, this would be known as a pan-hypopituitarianism. Pan, it affects all of the hormones, so none of the hormones are secreted appropriately. Signs and symptoms would be seen as hypoactivity in the target tissue. If it is due to a tumor, again, same issues with hypersecretion, you will see headaches and vision problems. If it is due to a genetic defect, then usually only a single hormone will be affected, and the signs and symptoms would show up as hypoactivity in that particular target and tissue. Dysfunction of the posterior pituitary. This typically affects the secretion of antidiuretic hormone. There are no known abnormalities in oxytocin secretion. Again, I can't emphasize enough, remember that these hormones are made in the hypothalamus and stored in the posterior pituitary until they are needed. One condition is diabetes insipidus. This is hyposecretion of ADH. Remember what ADH does. Antidiuretic hormone causes the body to hold on to water. If there is not enough ADH, you will start to dump water. The body will not be able to hold on to it. This could be due to tumors, infection, trauma, or radiation treatment. What you will see will be diuresis. This is due to the action of ADH. It is no longer able to affect the permeability of the nephron tubules. So as a result, the tubules cannot reabsorb water and it will be lost in the urine. You will also see thirst and polydipsia. These are in an attempt to compensate for the water loss. Another condition is syndrome of inappropriate ADH secretion. This will cause an excess or hypersecretion of ADH. This could be the result of the production of ADH-like materials by non-endocrine tumors. These also often are seen in association with lung, lymph, or thymus tumors. It could be the result of meningitis, infections, trauma to the brain, or infarction. General effect would be a buildup or an excess of extracellular fluid volume because the body is not able to get rid of the fluid. The next gland is the thyroid gland. Again, some review of the normal anatomy and physiology. The secretion of the thyroid hormone involves its synthesis by the follicle cells. These are the cells that make up the thyroid tissue. Storage of the hormone within the follicle. This is the compartment made up by a ring of follicle cells. And lastly, its release into the blood. The two thyroid hormones are T3 and T4. The 3 and 4 designation indicate how many iodines are attached to the molecule. I feel it is important to understand how this hormone is produced. The production of thyroid hormone begins with iodine trapping because both hormones contain iodine. The bulk of this iodine comes from our diet. The follicle cells within the thyroid will take up the iodide ion via active transport and then concentrate it. There is roughly 300 times the concentration of iodide in the thyroid compared to plasma. This iodide will then be converted to iodine and released into the colloid. The colloid is the fluid portion in the center of the follicle. In the colloid, this iodine will combine with thyroglobulin. This is what T3 and T4 will be produced from. Once made, T3 and T4 will be stored in the follicle. When they're needed by the body, they will be taken up from the colloid via pinocytosis back into the individual follicle cells, where they will be split off of the thyroglobulin. T3 and T4 then diffuse into the plasma for distribution throughout the body. But in order to be transported, T3 and T4 must combine to another protein. These are either alpha globulins or albumin. The main protein is called thyroxine binding globulin. This chart here shows how the hormone is produced. So this square represents the individual follicle cell. And then on this side, the follicle, that's the inner compartment where the colloid is. We can see on the slide of thyroid tissue, we can see a ring of follicle cells. This complete ring is known as the follicle, made up of individual follicle cells. The center portion is filled with fluid. This is known as the colloid. So again, we're looking at one individual cell. The iodide will be taken up by active transport and converted into iodine in the colloid. It will then be added to thyroglobulin, and this is what T3 and T4 are made from. And this is how they are stored. When the body needs it, T3 and T4 will be taken up by pinocytosis by the follicle cells, removed from the thyroglobulin, and released in the plasma for transport. Control of thyroid secretion depends both on the anterior pituitary and the hypothalamus. Everything begins with the hypothalamus when it secretes thyrotropin-releasing hormone. TRH travels through the blood and will stimulate the anterior pituitary to secrete TSH, thyroid-stimulating hormone. TSH is released into the blood and travels to the follicle cells of the thyroid gland, where it causes the release of the stored hormone. TSH will also act to increase iodine uptake and hormone synthesis by the follicle cells. Increased levels of thyroid hormone will then inhibit the secretion of both TRH and TSH. This is the negative feedback mechanism. So it will inhibit then the further secretion of T3 and T4. Increased levels of thyroid hormone will also cause as the levels increase, the body doesn't need to produce anymore, and this is what stimulates the negative feedback response. Increased levels of plasma iodine concentration actually act to suppress the thyroid gland. Increased exposure to cold will stimulate or increase thyroid secretion. We'll talk in a moment about the effects of thyroid hormone, but it helps the body to produce heat, and in this way you can adapt to cold. Emotions tend to have different effects on the thyroid gland. And this is showing the negative feedback loop. Hypothalamus releases TRH, that stimulates the pituitary to release TSH, that then stimulates the thyroid gland to release T3 and T4. As the levels of T3 and T4 build up, you see the negative feedback loop. Cold and emotions can stimulate the hypothalamus to end up producing more T3 and T4. And high iodine levels actually inhibit the synthesis of the hormone. What are the effects of T3 and T4 on the body? First, most T4 will be converted to T3 at the target tissues. T3 is more active and binds more readily to the target tissues. T3 and T4 will both be degraded by the target tissue, and the iodine will be released and recirculated back to the thyroid to be reused. Again, we've talked all semester about how the body is a great recycler. Every cell in the body is a target for thyroid hormone. Basically what it does, the main effect, are metabolic effects. It will promote protein, carbohydrate, and lipid use by our cells. It stimulates aerobic energy metabolism within the cells. Thyroid hormone has an effect on growth and development regulation, and it has an effect on the nervous system. Lack of hormone during either fetal development or the first year of life can result in mental incapacities in infants. Now, looking at thyroid pathophysiology, the defects can be in the thyroid gland itself, or it could be the result of the anterior pituitary or the hypothalamus. Signs and symptoms of altered secretion are related to the effects of T3 and T4 on the target tissue. First, looking at thyroid hypofunction. Here, hormone secretion is inadequate to maintain normal levels of target tissue stimulation. Generally, one will see a decrease in metabolic rate. This means less body heat will be generated. You will see sluggish muscle contraction, slow motility in the GI tract, which can result in constipation, and a decrease in cardiac output due to decreased myocardial contraction. You can also tend to see an increase in body weight. This is because calories are not used as efficiently, and the excess will be stored as fat. You can see a decrease in sex drive and abnormal menstrual flow in women. You can see depressed mental functioning, slow, dull responses, and the person always is complaining about being tired. One of these conditions is myxedema. This is reduced secretion of thyroid hormone in an adult. The name comes from the swelling that is seen around the eyes, lips, and fingers. Because there is a lack of hormone, the glycoprotein will become deposited in the dermis. This is the protein that would carry the hormone through the body. Well, there's no hormone for it, and this protein is still present. When this protein becomes deposited, it will bind to water, creating a gel that results in puffiness. This does not look like regular edema because there is no pitting or settling. Signs and symptoms include physical weakness due to a decrease in metabolism. Mental functions decrease. The person becomes slow and confused. It becomes difficult to adjust to the cold. They may go into a coma in very severe cases. And this condition can be fatal to the elderly. The next condition is cretinism. This is thyroid hypofunction in an infant. Here you will see impaired growth in tissue differentiation. The infant is called a cretin because they are abnormally short. Bone development tends to be affected more than soft tissue, so they appear stocky with a very thick body. Signs and symptoms include the short stature due to the reduced growth, an increase in subcutaneous fat, mental incapacities due to the lack of thyroid hormone to the central nervous system during development. They will have a thick tongue, causing difficulty in swallowing. They appear obese, but they are really not. This is due to normal size abdominal viscera in a smaller than normal body. So this makes them appear to be obese. They have scaly skin and dry, sparse hair. They have yellow skin due to the accumulation of keratin and reduced sexual development. One thing that's often associated with thyroid problems is the development of a goiter. A goiter is thyroid gland enlargement. Goiters are typical in hyposecreting states, but they are not restricted to hyposecretion. One type of goiter is a diffuse colloid goiter. Because there is a decrease in thyroid hormone, due to the negative feedback, you will see an increase in TSH secretion. This will be constantly stimulating the thyroid gland to try and produce thyroid hormone, but the gland is incapable. This will cause follicular hyperplasia. As a result, the follicle cells begin to secrete extra thyroglobulin into the colloid, and this is what causes the gland to then enlarge. Another type is a nodular goiter. This is where you have many irregular nodules in the thyroid. They form when regions of the follicle atrophy and fibrosis will take over to replace the normal tissue with fibrous tissue. This is common in females over the age of 30. Another type is a toxic goiter. This is when nodular goiters hypersecrete. So this is an example of a hypersecreting goiter associated with hyperthyroid states. And the last is a non-toxic goiter. This is a hyposecreting goiter, and they typically will cause problems due to its large size. These often can compress structures in the throat, especially the jugular veins. What can cause thyroid hypofunction? One common cause is a surgical resection or radiation therapy that are used for treatment of hypersecreting states. It could be due to a congenital defect, where either there is a lack of thyroid tissue or an inability to make the hormone. It could be due to thyroid trauma, any type of a penetrating neck wound, or can damage the thyroid gland. It could be due to thyroiditis. This is inflammation of the thyroid due to either trauma or an infection. An example of this is Hashimoto's. This is a fibrous infiltration of the thyroid tissue by inflammatory cells. Another cause is an autoimmune response against one's own thyroid. Here you make antibodies that over time destroy the thyroid gland. This is also seen associated with Hashimoto's. The last cause would be a deficiency of dietary iodine. This is an uncommon cause since the introduction of iodine, the iodine in our salt. Thyroid hypofunction. So what could cause hypofunction? It could be, another cause could be disturbances of the hypothalamus or anterior pituitary that would cause insufficient stimulation of the thyroid gland. And lastly, it could be due to various transient conditions that cause a relative thyroid hyposecretion. This is due to states of high demand for the hormone, typically seen associated with pregnancy and during puberty, during growth spurts. Therapy in a thyroid hypofunction is relatively easy and provide the hormone. So this is showing the flow chart for the etiology, various causes of hypofunction. Thyroid hyperfunction, now hormone is in excess, and you will see an exaggerated target tissue response. This is often referred to as thyrotoxicosis. Signs and symptoms include an increase in metabolic heat production due to the increased metabolic rate. You will see flushed skin and an increase in perspiration. These people often have a difficult time tolerating high environmental temperatures. You will see nervous excitability. They become very active both physically and mentally. They also tend to have insomnia, be irritable, have anxiety, and paranoia. You will also see hand tremors. You can see cardiovascular effects. Here that you will see the heart rate increasing. However, the blood pressure stays normal. You can think about it. When we were doing cardiovascular, we said in one cause of higher blood pressure, as the heart rate increases, your blood pressure increases. This is just different, opposite of what we were saying. What causes this? Think about it. The increase in cardiac output, which is due to the increased heart rate, is countered by the vasodilation to try to dissipate the excess heat that is being produced. So yes, you have an increase in heart rate that should increase the blood pressure, but you have vasodilation, which causes the blood pressure to decrease. So the two balance out. Their appetite and food intake will increase, but you often see weight loss and a decrease in plasma lipid levels. This is due to the consumption of the adipose stores to meet the metabolic demands. You can see heart failure and decreased contractility in the skeletal muscles. This happens as the body begins to use protein as an energy source. You can see exophthalmos. This is when the eyes protrude from the orbits. This may result in corneal damage. What causes this is an exaggerated sympathetic nervous system output that causes the pronounced retraction of the eyelids. This picture shows the exophthalmos. You will also see hyperventilation. This is to clear the excess carbon dioxide due to the increased metabolism. Remember, CO2 is another byproduct besides heat of metabolism. You will see diarrhea due to hyperactivity in the GI tract, and impotence or amenorrhea. What can cause a hypersecreting state? One condition is Graves' disease. This is seen in young women. This is an autoimmune condition where you will see hyperplasia of the gland. The gland can increase 2 to 3 times its normal size. You will also see a toxic goiter even though the TSH levels are low. Here, this is another example of an autoimmune destruction of the tissue, but in this case, it results in a hypersecreting condition. Why? The antibodies in Graves' disease are made against the TSH receptor. They bind to the receptors and stimulate thyroid secretion. These antibodies are more active than TSH because they are not broken down. So they bind and they stay there and continually stimulate the gland. Another cause would be a toxic multinodular goiter. These occur with no autoimmune association. This is a simple goiter that develops regions that begin to hypersecrete, and they do not respond to the low TSH levels. These hypersecreting foci often enlarge to form nodules. Another cause would be just idiopathic TSH hypersecretion that can also lead to a toxic goiter. And lastly, there's thyroid storm or crisis. This is when large reserves of the hormone are released from its plasma binding protein all at once. This will act to enhance the symptoms of an already hyperthyroid state. This can result in further increase in metabolism, causing hyperpyrexia, which is an abrupt increase in body temperature. This can have adverse effects on the central nervous system. It can also result in fluid loss due to the increased perspiration, diarrhea, and vomiting. And you can also see cardiac arrhythmias. Therapy in hypersecretion: either surgically remove a part or all of the gland, or use ionizing radiation to destroy portions of the gland. The problem with both of these conditions is that it will then lead to a hyposecreting state. Another option would be to use drugs that would suppress T3 and T4 synthesis. These drugs are often very expensive, so many people opt for one of the first two, either surgery or radiation. The drugs to treat the thyroid hormone replacement therapy is much cheaper than the drugs that are designed to suppress the thyroid. Our next gland is the pancreas. Remember, this is both an endocrine and an exocrine gland. We are going to look at the endocrine function here. The main function is, the endocrine function is to regulate blood glucose concentration. This is important because the brain depends on glucose as an energy source, and its concentration must also be regulated to prevent changes in the ECF osmolarity. The normal physiology of the gland as far as the endocrine portion. Within the gland, you will see groups of cells associated with the blood vessels, referred to as the islets of Langerhans. Within these islets, you will see three types of cells, each of which produces a different hormone. The alpha cells secrete glucagon, the beta cells secrete insulin, and the delta cells secrete somatostatin. We are going to focus on glucagon and insulin. First, the functions of glucagon. Glucagon results in glycogenolysis, lysis of glycogen. It stimulates the liver to convert glycogen, which is the storage form of glucose, into glucose. Gluconeogenesis, again, genesis being creation, neo means new. This is the synthesis of new glucose. The body will use non-carbohydrates to create new glucose. Typically, the body will use amino acids and convert them into new glucose. Lipolysis is the breakdown of fats into fatty acids and glycerol. The control of glucagon secretion is negative feedback. Low concentrations of blood sugar will stimulate the release of glucagon from the alpha cells. When blood levels rise, the secretion will be inhibited. The purpose of glucagon is to prevent hypoglycemia, i.e. low blood sugar. The functions of insulin are pretty much the opposite of glucagon. First is glycogenesis. This insulin will act on the liver to promote the formation of glycogen from glucose to store this glucose. Lipogenesis is the stimulus of the synthesis of fats. Once the glycogen stores are full, then the body will convert excess glucose into fat. Insulin inhibits the conversion of non-carbohydrates into glucose. We don't need any more glucose. It promotes the facilitated diffusion of glucose through the cell membranes of adipose and muscle cells. Again, adipose cells primarily for its storage. It promotes the transport of amino acids into cells, and it enhances the synthesis of proteins. The control of insulin is also negative feedback. It will be released from the beta cells when blood glucose concentrations are high and inhibited when low. The purpose of insulin is to prevent hyperglycemia. Also, as insulin levels begin to decrease, this is what allows glucose to enter cells that don't have insulin receptors, and this is primarily the nerve cells, especially cells of the brain. The main condition with the pancreas is diabetes mellitus. This is the most common endocrine disorder. There are two forms of diabetes mellitus. Type 1, which is often referred to as juvenile onset, also called insulin-dependent diabetes mellitus. This develops following a failure of the beta cells and will require insulin therapy. Type 2 is referred to as maturity onset or non-insulin dependent. Here you see a gradual onset of symptoms, and insulin therapy is not always needed. Many times the beta cells here can still make insulin, but the target cells no longer respond to it. What is the etiology of type 1 or insulin dependent? Common cause is an autoimmune destruction of the beta cells. This may be a genetic link or the result of an environmental agent such as a virus or a chemical. What happens is that these beta cells will become damaged. Once damaged, they undergo an inflammatory response that brings in the lymphocytes. Beta cell antigens, as a result of these changes, the beta cell antigens become altered so that now they appear foreign to the body. This will result in the production of antibodies, causing an immune attack on the beta cells. And this is what then results in the signs and symptoms of insulin-dependent diabetes. So again, there's an infection or a virus, exposure to a chemical or a drug, or a genetic issue that alter the beta cells, alter their antigens so they don't look like self, and this results in an attack. Signs and symptoms of insulin-dependent diabetes: hyperglycemia. This is high blood glucose due to the reduced cell uptake and an increased release from the liver. Glucoseuria. This is the urinary loss of glucose due to the high blood levels. The body's trying to get rid of this excess glucose. Polyuria. The hyperglycemia reduces renal water reabsorption. This is known as osmotic diuresis. Because there is so much glucose in the nephron tubules, this draws out the water in an attempt to dilute it. Osmotic diuresis. You will see polydipsia. This is an increase in thirst and water intake in response to the polyuria. You can see weakness, fatigue, and weight loss. This is due to abnormal protein and carbohydrate metabolism. The body's proteins are beginning to be converted into glucose. You will see ketoacidosis. This is the accumulation of ketone bodies resulting in metabolic acidosis. This is due to excessive lipid metabolism for energy. If they can't use glucose, the cells will start to break down lipids, and this forms oxaloacetic acid. A person can go into a hypoglycemic coma. This is because the brain is glucose deprived without the insulin, and as the insulin levels fall, this is how the brain gets glucose. Well, it can't do this. So the brain cannot maintain normal levels of activity, and loss of consciousness often results. So again, this is showing the pathogenesis of the insulin-dependent form. In non-insulin diabetes, the pathogenesis is not as well understood. Some ideas: there may be a genetic link. Oftentimes the beta cells are undamaged, or you might only see very slight fibrosis in the islets. Insulin levels are often normal or elevated, but the secretion is often delayed. Typically, you will see a loss of insulin receptors in the target tissue. What happens is because blood glucose levels are constantly elevated, the target cells feel, well, glucose is always there. We can always get it when we need it. So they downregulate the insulin receptors. Eventually, it gets to a point where they no longer are able to respond to the insulin. Another cause could be that the intracellular response to insulin binding of the receptors is abnormal. The insulin can still bind to the cells, but you don't see the same normal response of the target cells. You see hyperglycemia even though insulin levels are normal. Again, the cells don't have the target for them. This form is typical in obese over the age of 40. As I said before, high-calorie diets tend to cause the cells to respond by downregulating or decreasing their numbers of insulin receptors. You will see hyperglycemic, hyperosmolar, non-ketotic coma. This is due to cerebral dehydration. Water will move out of the brain cells to the extracellular compartment to try to compensate for the urinary loss. So again, here's the flow chart, and notice all of the question marks. We have these ideas that these are causes, but we are still unsure. What are some of the chronic effects of diabetes? And this is in both forms of diabetes. Typically, you will see widespread vascular and neurological changes. This is due to problems in metabolism. One thing that happens is you will see an altered glucose metabolism, and this is the result of some of these changes. Proteins become glycated. Some of this extra glucose gets added to the proteins. Hyperglycemia favors their formation, and once glycated, these proteins do not function normally. Some examples of proteins that can become glycated are albumin and hemoglobin. These complications often arise about 15 years after the hyperglycemia begins to develop. What are some examples of these complications? One is microangiopathy. This is small vessel damage. The altered carbohydrate metabolism will cause faulty deposition of basement membrane material in the vessels. This will weaken the vessel and interfere with the normal permeability. These glycated proteins in the basement membrane can also cause endothelial changes. This can result in platelet aggregation and a reduced blood flow. What happens as a result of this? You will see compromised wound healing, especially in the lower legs. Minor wounds can very quickly become gangrenous. You will see a depressed renal function. The faulty basement membrane of the glomerular capillaries will cause abnormal filtration, which over time can result in renal failure. It also causes damage to fine retinal blood vessels. These are often subjected then to elevated blood pressure. This will result in retinal damage, causing cataracts and glaucoma. Another complication is atherosclerosis. This is the second most common cause of death in diabetes, leading to myocardial infarction and cerebrovascular accident. This affects primarily the larger vessels. Chronic hyperlipidemia in diabetes promotes erythroma formation. Also, the hypertension in diabetics will also lead to rapid formation. Atherosclerosis plus small vessel damage can add to brain ischemia, which increases the chance of cerebrovascular accident. Also, these glycated proteins will contribute to more extensive and rapid plaque development. We talked about this back in the cardiovascular chapter. Another complication is peripheral neuropathy. This is sensory loss and skeletal motor dysfunction. You will see abnormal reflexes, numbness, tingling, and deep pain. It may also affect the autonomic pathways, resulting in bladder and bowel dysfunction, impotence, and fading. How do you diagnose diabetes? It is based on the presence of hyperglycemia, glucoseuria, and polyuria. These are all due to the lack of insulin secretion and are easy to test in insulin-independent diabetes. But in the non-insulin form, you need to run a glucose tolerance test. These tests the ability of one's cells to take up and metabolize glucose. What you do is you give an oral solution of glucose and then monitor the amount of glucose in the blood as well as in the urine over time. Treatment of diabetes? In the insulin-dependent form, subcutaneous injections of insulin are needed to attempt to restore glucose metabolism. Dietary intake must be regulated to match the insulin dose. In the non-insulin-dependent form, insulin is not often required. Many times it can be controlled by the loss of excess weight and through moderate exercise, which promotes carbohydrate metabolism. If drugs are needed, they will often take a sulfonylurea type medication. What this does is stimulate the release of insulin from the beta cells. Another form of diabetes is secondary diabetes. This is when insulin hyposecretion is due to something other than beta cell destruction or hormone resistance. It might be due to pancreatic inflammation or trauma, so some other problem within the pancreas that is affecting the islet cells. Pancreatic surgery that removes the islet cells, drug or chemical suppression of insulin secretion. And then the last three, acromegaly, Cushing's, or pheochromocytoma, these are other endocrine problems that can result in a secondary form of diabetes. Our next gland are the endocrine glands. Hormones from this gland help us regulate various homeostatic mechanisms that help us adapt to our environment. The adrenal glands are found on the top of each kidney, and they are made up of two parts. The center portion is known as the adrenal medulla. This is a group of irregular shaped cells found in groups around blood vessels, and these cells are closely associated with the autonomic nervous system. The adrenal cortex makes up the bulk of the gland. It is made up of layers of epithelial cells that form three distinct zones or layers. The glomerulosa is the outer layer, the fasciculata is in the middle, and the reticularis is the inner layer closest to the medulla. Each zone is responsible for producing a different group of hormones. First, looking at the hormones of the adrenal medulla. These include epinephrine and norepinephrine. Epinephrine is made from norepinephrine. The control of synthesis for both hormones is through negative feedback inhibition. Both can inhibit an earlier step in their synthesis. Epinephrine and norepinephrine, once made, are stored in cytoplasmic granules and then are released due to autonomic nervous system stimulation. 80% is in the form of epinephrine and the other 20% norepinephrine. Both are usually secreted during times of stress and help to prepare the body for fight or flight situations. The adrenal cortex has the ability to produce upwards of 30 different hormones. As a group, they are called the corticosteroids or steroid hormones. These 30 hormones are placed into three major groups based on their function. One group are the mineralocorticoids because they have an effect on sodium and potassium levels in the body. An example of a mineralocorticoid is aldosterone. The glucocorticoids regulate carbohydrate metabolism. An example of a glucocorticoid is cortisol. And the third group are the sex hormone precursors. These are known as gonadocorticoids. This is where the opposite sex gets the opposite hormone. For example, females have testosterone. Testosterone typically is made by the testes, but the adrenal cortex is another source of testosterone, or is the source of testosterone in females, and the opposite in males. This is where estrogen would be produced in males. The synthesis of all of the corticosteroids starts with the uptake of LDL by the cells. Cholesterol will then be released from the LDLs and then enter into the different synthetic pathways. These pathways are catalyzed by mitochondrial and endoplasmic reticulum enzymes and will result in the three major types of hormones. What controls the secretion of each of these groups? One is ACTH, which comes from the anterior pituitary. This regulates the release of the glucocorticoids and the gonadocorticoids, and also regulates their synthesis. Angiotensin II regulates aldosterone secretion. This is part of the renin-angiotensin system. Both of these are controlled through negative feedback. The cortex and the medulla together play complementary roles in helping the body adapt to stress. You typically will see an increase in cortisol and an increased release of epinephrine and norepinephrine in times of stress. A stressor is anything that causes an increase in cortisol secretion. This could be anything from trauma, intense exercise, a severe infection, systemic hypoxia, extreme temperature changes, pain, or emotional distress. The stages in the syndrome, it begins with the alarm phase. This typically will activate the medulla, causing this rapid release of epinephrine and norepinephrine into the bloodstream. You get this heightened rush of feeling that you can deal with anything. Then you enter into a resistance phase. This is the effect of the corticosteroids. They will provide a long-term response by providing a steady state compensation for the high demands generated by the initial emergency. So again, this is what allows you, if the stressor doesn't go away, allows you to deal with it for a longer period of time. However, if that stressor is not taken care of, eventually you will enter into an exhaustive phase. Here, the adaptation capacity is overwhelmed, and without therapy, this can result in a rapid decline and even death. As far as adrenal pathophysiology, most involve the adrenal cortex. First, we'll look at adrenal cortical hypersecretion. This is Cushing's syndrome, which is hypersecretion of the glucocorticoids. Signs and symptoms. The person often appears obese, but this is due to the pattern of fat deposition that is seen in the face, base of the neck, and the abdomen. You see this classic round moon face. You will see muscle weakness, bone loss, and bruising. This is all due to chronic protein catabolism. You will see systemic hypertension and hypokalemia due to sodium and water retention. Often you will see diabetes mellitus due to the prolonged hyperglycemia. Mental dysfunction and male pattern hair growth will be seen in women due to an increase in androgen secretion. And there are often many psychological disturbances due to the physical changes that are happening to the body. This hypersecretion could be due to prolonged ACTH secretion or glucocorticoid therapy for other conditions. There's often these symptoms are the same, Cushing's symptoms are the same symptoms you would see in somebody who is taking hormones or steroids for a long period of time. It may be due to an adrenal tumor, could be due to ectopic secretion of ACTH by a non-endocrine tumor, or it could be due to excessive output of ACTH by the pituitary or a hypothalamic tumor. Hyperaldosteronism is hypersecretion of aldosterone by the adrenal cortex. Signs and symptoms. This typically hits males more than females, and the common age is between 30 and 50. You will see systemic hypertension due to the sodium and water retention as a result of excess aldosterone. You will also see hypokalemia and alkalosis secondary to the sodium retention. What can cause this? It could be a cortical adenoma, a tumor. It could be idiopathic or a non-neoplastic cortical hyperplasia. It could be due to the excessive renal secretion of renin. Remember, the renin-angiotensin is responsible for the release of aldosterone. It could be due to a renal tumor or due to chronic volume depletion, which would indicate a need for excess aldosterone for sodium and water retention. Adrenal virilism is due to androgen hypersecretion, primarily in females. The signs and symptoms include beard growth, acne, deep voice, and hair loss. These 4 traits are known as virilization traits or masculine traits that develop. You will also see menstrual abnormalities and sexual precocity if this condition occurs in young males. Causes could be either hyperplasia or neoplasia of the cells of the cortex that secrete the androgens. An example of adrenocortical hyposecretion is Addison's disease. This is inadequate amounts of the corticosteroids. This could be due to destruction of the adrenal cortex through either autoimmune destruction, an infection, tumor, or infarction. It could be due to the suppression of ACTH due to high therapeutic doses of glucocorticoids, or it could be due to a congenital enzyme deficiency. Signs and symptoms would be slowly developing weakness and fatigue, loss of appetite, loss of weight, pigmentation excess. There is a connection between the corticosteroids, ACTH, and also melanin production. The person becomes very vulnerable to stress, and they can go into Addison's crisis. This includes fever, nausea, vomiting, hyponatremia, hyperkalemia, and hypotension. This is all due to, this also can result in circulatory shock. This is why when somebody is on steroid treatment for an extended period of time, why you have to slowly wean off of these steroids to bring back the production of ACTH. Otherwise, the person will go into Addison's crisis. Our last gland is the parathyroid gland. This gland regulates calcium as well as other minerals. This gland is found on the back of the thyroid gland, and it produces the hormone parathyroid hormone. This hormone acts to increase blood calcium levels and decrease blood phosphate levels. How does it do this? First, it stimulates the bone resorption by both the osteocytes and osteoclasts. Osteoclasts break down bone, and this will release both calcium and phosphates into the blood. It also acts to inhibit the osteoblasts, which are the bone building cells. So these first two will cause an increase in both calcium and phosphate levels. We want only calcium to be increased. So how do we get rid of the phosphates? Parathyroid hormone also causes the kidney to conserve blood calcium and excrete more phosphates into the urine. And lastly, parathyroid hormone indirectly stimulates the absorption of calcium from food in the intestines by influencing the metabolism of vitamin D. It causes the kidney to activate vitamin D, and this active form of vitamin D will control transport mechanisms to absorb calcium from the intestines. Control of this hormone is also via negative feedback. One condition is hyperparathyroidism. This could be due to a tumor or parathyroid hyperplasia. Signs and symptoms. This condition is more common in female. You will see a loss of bone tissue due to excess osteoclast stimulation. As a result, you will get bone weakness, bone pain, deformities, and fractures. You will also see hypercalcemia. This causes muscular and neurological defects as well as an increased incidence of kidney stones. Secondary hyperparathyroidism is due to a renal disease where phosphate is retained and calcium levels are depressed. Because calcium levels are depressed, this will cause an increase in parathyroid secretion to try to overcome. It may also be due to GI malabsorption or due to vitamin D deficiencies. The last condition is hypoparathyroidism. This could be due to the inadvertent removal of the glands during thyroid or neck surgery. Remember, they are on the back of the thyroid gland, so if you remove the thyroid, many times these are removed with them. It could be a hereditary gland deficiency, or it could be the target tissue insensitivity to the parathyroid hormone. This will result in hypocalcemia due to inadequate renal retention of calcium, a decreased GI absorption of calcium, decreased calcium release from the bone. It can cause weakness, faulty muscular functions, and altered mental processes.